All right, so DK crush is don't get led by the title about crushing your opponent, although that may be something that comes to mind. But there are actually scientific data and practical data why DK crush is the strategy you should do. And these are my disclosures. And this is the algorithm I'm using for bifurcation. So maybe a little hard to see, but we should not forget that provisional standing remains the key approach. So you start for bifurcation. The first question is the side branch big enough? If it's 1.5, you don't worry about it. If it is big enough, then are you likely to lose it? If you are likely to lose it, that's when you get into the two-stent strategies. And the way to do this, it turns down to the angle. When you have an angle that is less than 70, that's where DK crush, culotte, other bifurcation techniques are relevant. And the most common controversy there is, do you use the DK crush or use the culotte? I think the mini crush, the crush, those techniques have really gone away. And this is the illustration of the DK crush, which I'm not going to go over in detail, but double kiss crush is a complex technique. It has several steps. You start and you put a stent in the side branch, then you crush that stent, then you rewire, you do the first kissing balloon inflation, then you put your second stent, deploy that stent, then rewire and do another kissing balloon, and finally finish with a proximal optimization technique. So this is not something always easy. It can take several steps and can be a little complicated. And another thing that's interesting is that in DK crush, you want to recross in a proximal strut, because if you recross in a distal strut, what can happen, you can actually compress the side branch stent and have an area of unstented segment in the side branch. This is completely different than the provisional stent, in which you actually want to cross in a distal strut. But why is the DK crush the preferred technique? Because there is data, and people can debate and say, well, the data is mainly from China. They're done mainly by the same operators, Xiang, Liang, Chen. But nevertheless, we actually have data, which is not true for most of the other techniques. So we started with the DK crush, which was like 12 years ago, showing that DK crush was better than the classic crush. And then DK crush 2, it was actually also better than provisional technique. And then we'll go to the ones that are more contemporary, which is the DK crush versus culotte. There are many operators who are very experienced in culotte and argue that culotte is a good technique to have. However, if you look at the long-term outcomes, at 1 year, you do have actually less events in the DK crush group. And if you go out to 3 years, you clearly have much less major adverse events, mainly less revascularization in the DK crush group. So you should do DK crush in preference to culotte, because we do have a fairly large trial showing better outcomes both in the short as well as the long term. Moving on to provisional. I mean, you saw before that provisional is the preferred strategy if you have a side branch that is big but doesn't have a high chance of being lost. However, there is the DK crush 5 study that was presented at TCT a couple of years ago and published in JACC that randomized nearly 500 patients to either DK crush or provisional stenting. And the incidence of target lesion failure at 1 year was significantly less in the DK crush group. So even provisional didn't have as better outcomes. Now you can argue that some lesions are simpler and some others are more complex. And typically the more length you have in the side branch, which is the circumflex in most left main bifurcations, or significant disease, then the higher the absolute risk for having adverse events. The simpler the lesion, the lower the absolute risk. It's 18% versus 8%. But if you look at both scenarios, doing DK crush significantly reduces your risk. It's not statistically significant in the simple lesions due to sample size, but it is a dramatic difference, even more pronounced in patients with complex left main disease. Why is it? Why does DK crush give you better outcomes? And there are many potential reasons, but in my mind, it comes down to one thing, which is how often can you actually do a final kissing balloon inflation? This is a critical step for actually expanding the stent struts, both in the main vessel and the side branch. If you cannot do that, you have underexpanded struts, you have struts that are not in the right spot, and your risk for stenosis and stent thrombosis is going to go up. So with DK crush, it's nearly 100%. So the advantage of doing DK crush, you can reliably get back into both vessels and do a final kissing balloon inflation. If you look at provisional stenting, you can only do it 80% of the time. If you look at culotte, 85%. If you look at T-stent, 82%. So there's no other two-stent bifurcation technique in which you can actually reliably get back in and do your final kissing balloon inflation. And again, that's why you get, I think, the better outcomes. This was the editorial for the DK Crash 5, and the title was that DK Crash is the preferred and there's no pain, no gain. Because there's no question that DK Crash is complex. And this is my latest. I'm updating this after every once in a while, and I'm now up to 17 steps. I'm going to break down step by step. So it was 10, 11, now it's 17. So yes, it's a little complex, no question about it. But the question is, what is best for the patient? And that's what matters the most. And if doing those 17 steps is what makes the outcomes be better, then that's what we should be doing. How do you learn to do it? And again, YouTube is a good way to do it. There's obviously many presentations. This is actually the most viewed YouTube video I've posted. And we just had one recently based on a bench model showing actually step by step why is it better and how does it look on the bench, looking at the stents itself and why you can do the final kissing balloon at the end. But to summarize, DK Crash should be the preferred technique for true bifurcation lesions. And the reason is because of all the DK Crash 5 trials. We do have better outcomes compared to the regular crash, that was the DK Crash 1, better to culotte, that was DK Crash 3, better than provisional DK Crash 5. And yes, it is more painful, but without pain, there is no gain. Thank you.